morning, everybody. Welcome to another session of cerebrovascular Q&A from Seattle Science Foundation in Swedish. My name is Matias Costa. I'm one of the cerebrovascular fellows, and one of my colleagues here, Leonardo Brasiliense, is going to introduce our speaker today.
Hey, good morning, everyone. It's an honor to be here. It's a real pleasure to have Dr. Hanel here present us today with the. This has been made possible by the SSF, Dr. McDougall, and Matthias, who have put all the background work. It's really a big honor to have Dr. Hanel talk about giant aneurysms. Dr. Hanel is the director and now chair of stroke at Baptist Neurological Institute in Jacksonville. Dr. Hanel has extensive publication on this topic. He has been the primary author of a lot of papers on flow diversion and has had extensive research on not only translational, but also lots of clinical research on cerebrovascular. Dr. Hanel has also been a speaker in multiple countries on this topic, and it's a true honor to have Dr. Hanel here. Without further ado, I'll just let Dr. Hanel take away.
You can share your screen, Dr. Hanel. I'm going to stop sharing. You're mute, I believe.
Can you see my screen there?
Yes, that looks great.
Okay, yeah, it's good.
Perfect. Thank you, Leo, for the introduction, and it's always great to see good old friends. Camero and we overlap at the Barrel when I had the honor of spending a year watching his work and learning from him, from Robert, and many others. And since then, we became friends. And it's always great to see what he's doing with the Swedish team. And Matthias, Corey, thank you for coordinating and inviting me to be part of this Seattle Science Foundation TV. I think that's one thing we learned positive from COVID, that we can communicate really well and exchange information in a very dynamic format without necessarily being face-to-face. This is our home here in Jacksonville, and this is what Leo had to drive to get from Jacksonville to Seattle. I'm not going to say that he made a pit stop in Tucson there, but it's a 45-hour drive. That's why we were using the internet to enhance that. Even with a fast car, as Dr. Monteith, will take a couple of days to get there. So thank you again, team, for the opportunity to share what I think I learned, and you see here through the next couple of minutes. When we talk about giant brain aneurysm, it remains a very humbling condition because if we squeeze all together data-driven intervention, like we have, for example, for stroke, on the giant aneurysm side, I think it remains a super nice art of mixing and matching the tools that we have available based in your case experience, based in what you learned through the years, but a lot based on what happened on the last case that you treated, and that will drive one way or the other towards treatment. This is our team here, and I know you guys have a tremendous team over there. A lot of the data behind this was work done by our research fellows, Dr. Cortez and Dr. Benalia. Those are my disclosures. We all know the problem when we're dealing with brain aneurysms. It's a very common problem. If you go by 4% prevalence, US population, there are 12 million walking around with a brain aneurysm. Fortunately, this terrible problem, a giant brain aneurysm, at most is 5% of these cases. We all know the risk of bleeding varies by size and location, and when it bleeds, it's a bad problem. We know that when we're dealing like this giant aneurysm, and you see here this lady with this ophthalmic aneurysm, you see how we're going to be treating this, but we know that risk of rupture is highly dependent on the size of the aneurysm. And if you add size and location, posterior circulation specifically, you're talking about a much higher problem. I think it is very important to start with this because when you're talking with a patient and a family, counseling about when we're dealing with a brain aneurysm, you got to be careful that you don't start quoting numbers from general publications like I've seen before. Somebody talking about a giant middle cerebral artery aneurysm, clipping quoting a 3% complication rate, or a flow diverter for a giant ophthalmic rate, and a very experienced interventionist quoting a 1% complication. That's not good to guide that family because that's not the natural history for this, with or without treatment. So if you're putting yourself in a situation that we all know today that this risk is higher. So you gotta tailor your conversation based on the natural history. If you leave this alone, risk of this rupturing is at 30-40% in 5 years. And if we treat, you're talking about 20% M&M, give or take. So you gotta set up the tone when you're discussing. We know for all modalities, including observation, the natural history, the results are worse with the size of the aneurysm. The larger the aneurysm, the worse the results. Anterior circulation better than posterior, and I'll show you some data here. But this is true for clipping, this is true for bypass, this is true for coiling, this is true for flow diverter. And we're getting much better on the endovascular. The recurrence rates are high also, depending on the size of the aneurysm. And we know endovascular still lags a little bit behind, but we got much better since the inception of flow diverter. You gotta know this. If you're young, you're dealing with the cerebrovascular, all of us dealing with this problem needs to be aware of these numbers because we are proposing higher risk treatment, but the natural history of this, if we leave it alone, this is just displaying a different modality graphic. You see here that the rupture rate is going to be much higher for these aneurysms. Looking at ISUIA data, and if you look at the Japanese data, this is also there. Very interesting to say, a very low representation of these giant aneurysms on the unruptured series, probably because they treat this. This does not represent 5%. It barely represents 1% of the patients that were on that population. I just anecdotal, there's not much written about that, but going all over the world, it's pretty clear to me that the prevalence of giant aneurysms has to do with cigarettes and has to do with socioeconomics. We go to my country, unfortunately, Brazil, socioeconomics are worse than US and Canada. And we see way more giant aneurysms on those populations. And this is there just as a side note. Every time we deal with a giant aneurysm, naturally we have some guidelines and some, and I'll share that with you here. In general, based on the beautiful study that was done by Dr. McDougall when he was at the Barrow, the BRAT, and the ISUIA, and I said, we know endovascular has lower morbidity. And in general, when we're dealing with a brain aneurysm, not only giant, but aneurysms in general, endovascular is first line. And if the endovascular treatment is complex, we turn to microsurgical. And if the microsurgical treatment is simpler, we'll go that route. And if both are complex, then it's a case-by-case discussion. But in general, endovascular first has been our routine for many years, and the better the technology gets on the endovascular side with endovascular endosaccular devices and improvement of flow diverter technology, like in that panel keeps swinging towards that. Naturally, when you're dealing with a giant brain aneurysm, it's hard to leave it alone, but I have a handful of patients during my career here in Jacksonville that decided against treatment. The patient, you counsel the patient, you have an 80-year-old with a giant top of the basilar aneurysm without symptoms, and you present a 20-30% M&M to this 80-year-old lady. She said, "Doctor, thank you very much. I'll wait for my subarachnoid hemorrhage, and when the day comes, I'll die in peace. I don't want to be exposed to this 20-30% risk up front." So this happens, but in general, we don't counsel that direction because of the natural history. For giant aneurysms, all tools are on deck. I think you've got to be in a place like we have here, like you guys have at Swedish, that can have all this gamma of opportunities and options for the patient, because in some cases, it's simpler to turn to the right. In some cases, it's simpler to turn to the left. And I'll show a bunch of cases here that illustrates that. We don't have this anymore. I like this quite a bit for giant aneurysms. We don't have our Onyx HD 500. It's a rare bird. Together with a high flow bypass for cavernous aneurysms, flow diversion also kill Onyx HD 500, and that is not available anymore. But clipping, coiling, stent coiling, today flow diverter assisted coiling, and a bypass with clip reconstruction, there's out there. I think that remains, and I'll show you data for that. Surgical morbidity favors endovascular. Efficacy, you may discuss that it still favors surgical treatment, but we know since flow diverted, this has been way less significant. Very interesting to see. Jean Raymond published a couple of years ago a nice paper called Fiat study, where they randomized a series of patients in 3 centers in Canada showing not so good results with flow diverter. And they just published this year a much bigger version of that, where when they compare flow diverter to other endovascular technologies, the morbidity of flow diverter was less than half of the other modalities, and the complete occlusion rate was at least 50 to 70% better with flow diverter. So we know this pendulum is swinging quick towards endovascular. How to make your decision? Naturally, this is a very local decision. We can talk about Dr. A, B, or C. You can talk about Saruhachek, who gave flow diverter giant experience. You can talk about Mike Lawton, because Robert Spetz is retired, a giant aneurysm. That is good to know, but you got to see how that applies to your local skills and to your local reality. And that depends where you are. You're watching this all over the world. It's very hard to translate a US reality where we can open any flow diverter and have 2, 3, 4 flow diverters available, or go to a big hospital in the Philippines where all you have is 3 shapes of clips that you have available to treat an aneurysm. So that you have to tailor that to your reality. And the rest of the talk, we're going to be focusing if all things are perfect, all tools are available, how we would manage that. And we know many places are not as fortunate as we are, and we have to be aware of that. Age of the patient, aneurysm characteristics, where the aneurysm is located. If you have 1 or more lesions, all this plays a role in the decision. Those are the tools that we have on our deck. For a microsurgical treatment of giant aneurysms, we can use clips and microsurgical anastomosis to do reconstruction of vessels, deconstruction, shut down, trap, with or without flow replacement. And I think one that we lag behind, even though our numbers are getting better in terms of our results for compression syndrome, especially cranial nerves and brainstem. I think with microsurgery, we can do a faster decompression that we can do when the vascular tools is still at this point. Naturally, there are many challenges that we're doing with this with microsurgery. Thrombus on the aneurysm wall, narrow spaces. If you look at the series of Dr. Spatzler for cardiac stent still, that I think also went away because of no need for the procedure. You talk about a 30% major M&M because of the complexity of the lesions and the morbidity added by the procedure. But those are all constraints with regards to that. When you look at endovascular treatment, we're talking about reconstruction, deconstruction, and decompression. And with flow diverters, we know 50 to 60% of the aneurysm, if you don't add coils, you're going to see a regression, and we'll go through some cases here. But our major enemy here with giant aneurysm is delayed aneurysm rupture. And we know from coiling before flow diverter that in spite of the coiling, we saw a good number of patients improving from all kinds of theories of why that happened, decreased pulsatility. So even though you're perpetuating the mass effect, quote unquote, of the aneurysm because of stuffing that with coils, there's still some room for retraction of the clot. If you remember, the volume of filling of the aneurysm at best with coil is about 30%, and on giants it's probably going to be way lower than that. So 70% of the mass will be thrombus that has an ability to retract. Aneurysm fillers, those are our tools with endovascular, with coils. We don't have liquid embolic anymore for aneurysm specifically. All endosaccular devices today are too small for giant aneurysm. If you think about the largest web is 11, 12 millimeters. Contour experience is still very limited on that. To put a 14 millimeter contour on top of a 25 millimeter aneurysm, I think nobody has much experience with that to say anything meaningful at this point. We do work a lot, and I think that's our strongest asset on endovascular is parent vessel remodeling with stents, but especially with stents with many wires, aka flow diverters. Many challenges on the endovascular treatment of giant aneurysms related to access, to the vascular anatomy, thromboembolic events. But for me, the number one that I worry and I fear for my patient when I'm dealing with a giant is delayed aneurysm rupture. We had a series of patients that succumbed from this, and we try to study it and try to strategize to decrease that. And another one, I'll show you one case that went well for one of these dolichoectatic vertebrobasilar atherosclerotic, like the brain version of abdominal aorta aneurysm, the brain version of a AAA. We're making some small strides on that, but we still have the issue of the device never healing on the wall of the aneurysm. That's one of the barriers that we have for those complex lesions. I'm going to spend 5-10 minutes here talking about what is there in the literature, and I gave you a 30-second snapshot of that. All that we have there are single series, vast majority retrospective, self-adjudicated, and we know in terms of science the value of that. It holds about the weight of the paper, but that's what we have. And again, we have to be fair, we have to be open about that. There are many issues with the prevalence and the heterogeneity. The lesions are very heterogeneous. This is a very interesting one. It's a meta-analysis, and I think Peter Varkozik, that is the chair at Charité in Berlin, and his team did a meta-analysis. And if you're interested on the topic, it's a heavy manuscript, but I think it's worth the time to read. And they try to frame the problem as a proportion of good outcome, and they center that. They review a lot of case series, and if you look at here, they start with the case series with 4 aneurysms or more. So very small series were included here, but they got you a good number of aneurysms, over 1,200 aneurysms. And if you look at this, you're going to see that the outcome of this manuscript, this meta-analysis, is very similar for endovascular and microsurgery. But again, this is not a head-to-head. So in my opinion, you're comparing apples with oranges. And I think the only way this is going to be answered is if you have a giant ophthalmic and compare modality A with modality B. If you don't do that, then you're picking and choosing. I do pick and choose what is best for one, what is best for the other. And then the results are skewed because of that. But I think it's very interesting. There are some hints from the manuscript, in spite of all the noise that you get on this meta-analysis and all the bias that I just shared briefly with you. You see here that is slightly better results, not statistically significant on their analysis. But if we start looking at that, you see that when you look at the locations of the aneurysms, and that's I think is important for us when we're discussing this with families. Anterior circulation, aka anterior circulation, internal carotid artery, the best results for giant aneurysm. So if you compare a carotid, ophthalmic, PCOM, and they were, because of the age of the studies, there were cavernous aneurysms included on that. And for that, I think the answer is pretty clear, whatever place you go, where before we're doing BTO, pass the BTO, occlude the vessel, fail BTO, partially low flow bypass, totally fail, high flow bypass, and sac the vessel. That's thankfully is history, because there were morbidity, and we lived through that in very good places doing bypass, but there is morbidity of high flow bypass that is probably underreported on the literature. That today's history. In general, a giant cavernous aneurysm today is going to be managed with a flow diverter unless the patient cannot tolerate that. And very commonly, the patient will go to a parent vessel sacrifice in some place they cannot afford a flow diverter. But you see here a dichotomy, right? You see the results for giant on the anterior circulation, specifically the carotid, compared to the posterior circulation. Another one that's super interesting on their paper, they would quote, after 45, every year that you live, your result is 0.8. I like to simplify life. So for every year after 45, drops 1% your odds of good result. So if you go to be 85 and you start at 90%, your result is going to be 50-50, good or not. So that's something that we have to have in mind when we're dealing with these patients. Another one that I think is pretty clear here, just to one more time emphasize the difference on the location for these giant aneurysms. If you're dealing with aneurysms on the carotid artery, there's a 5 times higher chance of getting a good outcome compared to patients with aneurysms on the posterior circulation. So that's a given. We all need to know that and be very respectful with this when we're discussing this openly with the patients and the families. This is an old paper that Jerome Bebeck put together, a Buffalo series of giant aneurysms treated by endovascular before flow diverters. And you see here that the M&M at the end is about 60% for the rupture cases, and is about 50% for unruptured. So big M&M by endovascular treatment before flow diverter, very, very humbly. When we start to get into more current endovascular, you see here, when you look at this meta-analysis done by Vince Constellat and his team from Montpellier, you see here, if you compare a reconstructive technique versus a deconstructive technique, you're going to have more complete occlusion, but actually it's very interesting. There's a higher complication rate for parent vessel occlusion, and a very similar complete occlusion rate if you look at the long-term results for the rupture. For the unrupture, the deconstructive technique did better. We look into that on a manuscript that Dr. McDougall was with us. This was Intrepid, a combined series of 906 aneurysms treated with a pipeline early on. So inside that population, we had patients with giant aneurysms. And this was the first time that we raised the flag that this complication, delayed aneurysm rupture for giant aneurysms, was definitely a problem related to size of the aneurysm. Before that, very commonly, people were quoting a 1% complication rate. We know that on this cohort, this number was 4.5%. And in another prospective series named Aspire, that number got to 10% in patients with just anterior circulation. Probably if you had a higher representation of posterior circulation, the problem would be worse. But you see here, the M&M gets higher according to the size of the aneurysm. And we published another segue paper on that. You see here for giant aneurysms, the morbidity is 20% and the mortality about 8%. So still with flow diverter, we're about 30% M&M when we're dealing with these aneurysms. I think we're better today than we were there. How much better, I think time will tell. This is history. As we told you, this was my very first flow diverter I took this patient from Jacksonville to Rochester, and I treat her with Dave, Harry, and Giuseppe over there. Pretty large, almost giant, cavernous. This became history. I think there's not much discussion today when this patient comes to us. If you decide to treat this aneurysm, flow diverter with or without coils, that's one of the locations that are much less aggressive with coiling. I like the volume reduction on the aneurysm. And I knock on the wood, have not experienced a delayed rupture. I know many people have seen that even with cavernous aneurysm. This is history, right? This is 15 years old, about 15 years old. 2 flow diverters, the pedrolytic eclipse sign, and Photoshop, the aneurysm disappear. Another one of the same. So cavernous giant aneurysms. The discussion for me today is vessel is too sick. The patient cannot tolerate do antiplatelet for whatever reason, GI bleed, and we see this once in a while. Then you go through other modalities, aka number 1, BTO, possible parent vessel sacrifice. But in general, that's a flow diverter domain. That's one giant aneurysm that I think we have good. And probably those numbers that I showed you from the meta-analysis probably are even better now, because a lot of the carotid aneurysms, the giant ones, are on the cavernous location. So another one, more of the same, multiple flow diverters, DynaCT to show that in spite of using devices of the same size, and you see because of the complexity of the anatomy, sometimes you don't have a perfect overlap, but it works. And here's the follow-up 8 months later. Another one just showing the same, and in spite of the curvy anatomy, Photoshop effect, like I like to say, giant aneurysm disappear, nice and heal. This one illustrates what we lived through before flow diverter for these lesions. This lady underwent coiling at an outside hospital. It came to us with a recurrence of this aneurysm right about the time where flow diverter was coming. We finished puffs and we're waiting for the approval. So I offered her to wait. She didn't want to wait, so we treated her with Onyx HD 500. 9 months later, worsening headache. You see here, beautiful Onyx HD 500 where I had my balloon. For those that are not familiar with this, we used to put a balloon here to our rest flow and inject this thicker Onyx. The Onyx that we use for AVM, AV fistula, is an 18 or 34. This is a 500. So the viscosity here is way, way, way thicker. So it's supposed to stay where it is. Remember, Onyx, a non-adhesive material. 9 months later, the Onyx cast was inside the aneurysm, and then we treated her with flow diverter. And that's how empowering this tool is. You see here, the flow diverter place. And again, just like Photoshop, beautiful healing of the vessel with cure of the aneurysm. You can start going higher. So we're going away from cavernous. We're getting higher on the internal carotid artery. This is a guy that was treated with coiling, hydrocoil, 2007. I was lost in follow-up to a colleague physician here in town. Till he come back in 2020 with this. You see his coil mass on his follow-up CT right there. And then he turned that into this. So that aneurysm grew a lot. And a simple carotid terminus aneurysm turns into a partially thrombosed aneurysm with typical flare changes associated with that. And that's what we have. The filling component right there and this big thrombosed sac around that. You see what happened to the coil mass. This patient was never retreated. You see this completely wild coil pattern there. Here you can discuss, not a great case for direct clipping without that mass there. Patient's young, so we discuss options of bypass and parent vessel sacrifice. Again, I think endovascular does a very good job here. Patient has a good day one on the other side. So my plan here is for a flow diverter from M1 to distal ICA and coil the aneurysm. And if this doesn't work, you still have the back door to come through the ACOM and still coil more and shut down the A1 if an endo leak occurs, and it can happen. So this is his follow-up 12 months later. Beautiful remodeling of that. Here's the coil mass that we add. This is his pre and this is his post. with reduction of the flare or T2 signal change around, and now the aneurysm is thrombosed and resolved. And that's, again, his follow-up in the longer term. Going beyond that, we can use this also for aneurysm more complex on the middle cerebral artery. I'm not a big fan for flow diverter and MCA bifurcation, and we'll talk about that later. But for this entity, I think flow divert is great. This large, giant, depending on the dimension that you measure here, this lady underwent clipping, as you can see here, for a bifurcation aneurysm, and she developed this M1 trunk aneurysm. I think this is a great domain for flow diverters. And here is her treatment with a single pipe. She stays on that, on being CT, follow-up CTA in 6 months, and a year later, all perforators preserved, no trouble with ischemia, and a nice remodeling of the aneurysm. Do we have any issues with endovascular treatment of giant aneurysms? Absolutely. We know that. There's so many issues that we study and we keep learning from and getting better, like bleeding complications from dual antiplatelet. You gotta prepare if this patient has cranial neuropathy, if this patient has brainstem compression, you gotta be prepared for worsening mass effect. If you do coiling or not associated with your flow diverter, this can happen. There's a good chance this will happen, and you got to be prepared to deal with that, to contemporize that with steroids and so forth and so on. This is the most feared one, and I'm going to dig deeper into that one in a second. But thankfully, this remote hemorrhage, as Cameron published, with foreign body migration to the parenchyma leading to hemorrhage, microemboli, ischemia turning to hemorrhage, and other potential mechanisms. Thankfully, what we learned a lot with dual antiplatelet regimens and even triple therapy, as I show you here in a second, delayed thrombosis. Thrombosis of the construct is a rare event in this population. And side branch occlusion stenosis is a problem, especially when you're dealing with the posterior circulation. Couple of cases in more complex aneurysms, we talk about the non-healing situation of these metal constructs. There we can have growth in spite of remodeling. I'm very much looking forward to see what we're going to learn from optical coherence tomography, where we're going to be able to look at the device from the inside. All these theories about, oh, this is the vasa vasorum of the aneurysm making it grow from the outside. I think what we're going to see is that the device never endothelized. So there's an exchange that we don't appreciate on the angiogram. There's an exchange between lumen of the aneurysm and lumen of the vessel, keeping the aneurysm alive from that. If we can totally close, I think we'll decrease the occurrence of this aneurysm growth in spite of good angiographic results. Not that the vasovasor mechanism does not exist. We've seen that with Hunterian ligation of giant aneurysms, that you close the carotid, and a year later the aneurysm starts to grow in spite of no flow demonstrated on the aneurysm. I'm going to show you a couple of my failures here. I think it's very important to remember that this is the prototype for delayed aneurysm rupture. It's a giant ophthalmic aneurysm with a neck that is not that bad. So by definition, this is more than 4 millimeters, a wide neck aneurysm, but it's not a terrible wide neck aneurysm. This was early on my experience. I coached this lady. Look, this is a best option for you. She failed a BTO at her age. I said, let's treat this with flow diverter. Put a single device there. I was super happy. She went home. This is her MRI that Leo published on our series, first series on the WI post pipeline. This is about 60%. I thought this was going to get better with the shield, and I'm not convinced. We're about to publish on that. Seems that these numbers are pretty similar in spite of shield and everything that we changed in our access on dual antiplatelet. But this is her 5 days later. This is a carbon copy of the first paper from Europe, from a silk delayed aneurysm rupture, ophthalmic aneurysm, large neck, somewhat wide. The patient ruptured his aneurysm, and thankfully she survived. You see that she ruptured right at the dome. So in spite of all this thrombus on the aneurysm, she ruptured at the top of the aneurysm. She came to us, we put an EVD on a stealth guide that didn't stop her pelvics because you don't want her to lose her left carotid. But you see here on this angiogram, the clefts that we have on the thrombus that allow fresh blood to keep that thrombus. And then there's a cascade between thrombosis and thrombolysis because of this persistent flow inside the aneurysm. And this is her, she survived. And if you look at her 2-month post CTA, you see exactly where she ruptured. You see a daughter shack that was never there before. She ruptured right at the top of this darn aneurysm. Another mechanism that has been proposed, and this is Adam Archer and his funny acronyms. This is a mid-basilar aneurysm that they did a third ventriculostomy in Memphis, took a picture from above of this monster. Adam discussed with a bunch of us and decided to do this with a single flow diverter and shutting down the other vert. And this is what happened. He coined the term fat man pants syndrome. Just like when you're a bit overweight, you go to bend to grab something from the floor and the bottom of your pants just break right in the middle. You see here, this is not a focal rupture, it's a linear tear on the top of that basilar aneurysm on the post-mortem of this unfortunate lady. So the volume of the clot got too big and literally didn't tear the vessel wall. This happens. We saw this. Camera was a co-author on PUFs. There was one case of a delayed cystic fistula. Back then, this was not well recognized. This happened on PUFs. And for sake of time, I'll show you, we'll talk about that. When you look at this 30,000, all aneurysms are the same. That is a mistake. Looks like this number is small. And we talk about the 4.5 on Intrepid. And we talk about the 10% on Aspire. So out of 21 aneurysms on this prospective series, 2 of them ruptured. So you got to be very cognizant of this and strategize for that. From all this data, and hopefully we're getting this paper finally published. This is a work that we put together, meta-analysis of all these giants on this 3 pipeline series, PUFs, Intrepid, and Aspire. It looks like if you have multiple pipes, higher mesh density, and coils, looks like we have a lower aneurysm complication rate. We talk about this. I think there are many mechanisms for that. You didn't cover the aneurysm completely. If you look at Matt Gooney's lab, if you touch the vessel from the inside with any microcatheter microwire, you are creating endothelial damage. Sometimes you could be creating already an unstable situation damage through and through on a giant aneurysm to get to the other side. So intraluminal manipulation. So many different mechanisms for this. We know this is related to size. So you got to strategize. Think about other options. Mesh density, covering. Steroids, I use it. I'm not sure if it makes a difference for that. I think it helps with the headaches and helps with this cranial neuropathy. Amir Hurusho on David Kalm's lab did a super nice animal study showing that if you coil these aneurysms, you decrease inflammation marked by metalloproteinase. So coiling of a aneurysm together with the flow diverter decreased inflammatory markers measured by MMP. So this is a newer case, similar problem. This is the one I showed a second ago. Giant ophthalmic. This is a case of my partner here. We're doing this flow diverter. We coil. There's no contrast penetration. My vote is put a second flow diverter. Tight band was not easy to put a first one there. We decide to keep just one flow diverter. We're recording this as a teaching case. Chris Morano is with us, so we decide to keep this as one flow diverter. Lady comes back to the office seeing Dr. Sauvageau with a bad headache. So if you see what happened to her here, very similar what we saw on the other patient. On her case, you see this big cap here of clot. So she ruptured this aneurysm after treatment. And look at the coil mass in relationship to the flow diverter, and look on the follow-up. the coil mass jump, and thankfully I think saved her life because the coil mass tamponed the rupture spot. So we went back and put another 2 flow diverters, and she survived and she did well. She lost her ophthalmic artery for the record here, but she did great. So the way I strategize when I see these patients today, I think carefully counseling, you gotta discuss this with the patient and the family. They need to be aware that we don't have a perfect science. They need to be aware that this can happen and this can be a life-threatening situation. I think you can consider to stage, and I will go back to that. I think coils do help on the situation, and I think multiple flow diverters do help in the situation. And I'll show you a couple of different strategies. Naturally, this one, the cat's out of the bag. I treat this one with Robbie Talk when I was at Mayo, has this giant mid-basilar aneurysm. So we coil this aneurysm, let this boy recover. Bilateral decompressive craniectomy is 18 days in hypothermia, a very prolonged course. He survived. We knew this was a Band-Aid therapy, came back, put a flow diverter. So staging, coiling, and flow diverter. We use that sometimes in unruptured aneurysms. This is another one. We did this a couple of weeks ago, Dr. Nima and I. This patient came with brainstem compression syndrome, unruptured, normal lumbar tap. So this is his angiogram. And this is something we have to discuss, right? This patient here, he has a good PCOM. So there's a good chance if we do an Alcock or a balloon test occlusion, he would tolerate sacrifice of the basilar artery. So when I see this guy, for me, there are 2 options: flow divert assisted coiling or parent vessel sacrifice. You can come from the left here and slide the clip just distal to the aneurysm and do, you potentially could get lower and trap this, but I think a distal clipping would be a reasonable strategy here. Whatever what you're gonna do is high risk for this patient. Patient has to be aware of that. So we decide to strategize. Let's try to do coiling, let the coil heal, and then we'll come back later and do flow diverter. So no blood on the subarachnoid space. We did coil this aneurysm. This is the final coiling result with balloon remodeling. And the patient did well for 48 hours. So no stents, well for 48 hours. This is his post-op MRI. Couple of the WI hits, we expect that. This is 48 hours later. He's feeling worse. We decide to go for an angiogram. Before he gets to the angiogram, he has even a worse, stronger headache, and then he bled that aneurysm. Just coil. There's no flow diverter here. So delayed rupture post-treatment with coiling alone. That tells you about the instability of the situation that can happen. So stage coiling and flow diverter is a valid strategy. I believe that, but it's not perfect either. So there'll be shortcomings on that. Unfortunately, he did not survive that. Different one here, happier ending. This lady has 2 giant aneurysms. She's blind on her left eye. She has a ophthalmic giant, and she has a carotid terminus aneurysm that is about 20-25 millimeters. So here's her 3D, and on her, we decide to go multiple pipe and coiling. So we start by distal aneurysm, coil that with a flow diverter in place, pull the catheter back into the ophthalmic aneurysm, put a second flow diverter, and coil that. So double bubble, super nice result with complete occlusion. Last 5 minutes here, if we can. We'll talk about posterior circulation and other alternatives. I told you all tools on deck, and all that I show you here is endovascular. When we're dealing with posterior circulation, you gotta be thinking about strategies. Mass effect can get worse. So we have all this thought process when we're dealing with a complex flow diverter. We're not talking about a 5 millimeter basilar tip. We're not talking about a 7 millimeter AICA aneurysm. We're talking about complex aneurysms, giant aneurysms. I think you should have this in your mind, what I'm gonna do to deal with that. We just published this combined series of using triple therapy, and I'll show you a case here where this, in my opinion, applies, but I think this is important to think about because combining for this giant dolichoectatic aneurysm that a holobasilar disease, combine a DOAC to the aspirin and Brilinta therapy. has decreased significantly the thromboembolic events, aka thrombosis of perforators on this patient. That is number one cause of MNM on that. Start simpler, partially thrombosed, patient present with seizures, dissecting aneurysm. You see the filling component there. I don't want to deal with this risk of rupture, so I go and coil that and put a flow diverter, and you come back a year later. So this is, for me, rather straightforward today to treat this with an endovascular. Duke Sampson likes to call, and he coined this very large and giant. This is not a giant by definition. This is a bit smaller than 20 millimeters, but it's a complex situation on the posterior circulation. This lady presented with a stroke, was found to have this partially thrombosed aneurysm. We put her on aspirin plebs and didn't touch. She has a thrombus right here inside the SCA. So if you drop the pressure here with a flow diverter, you can potentially shut down that SCA. So let things remodel. Let things remodel. Aspirin and Plavix for a month. You see her aneurysm is getting larger just because you're excavating the thrombus. But now the SCA is clear. You treat her, simple flow diverter. 12 months later, you come back, and this is 2 years later, totally remodel. And here you see your mass effect on the peduncle, totally gone on the follow-up. So that's the beauty of flow diverter without coils. Another one, on this one, I didn't dare do this without a flow diverter, without coils. This reminds me of a case of my fellowship. The only cardiac stands still that I've seen in my life. That was very clear to me that I was not going to do that here. 39-year-old female with just had her fourth baby and has this monster mid-basilar trunk. We did a reverse Alcock test. We just put a balloon on the basilar and inject through she has a good become. So basilar sacrifice would be reasonable in her case. We discussed with her, we decided for pipe coiling, and that's what we did for her. Again, she got a prophylactic VP shunt before starting doing antiplatelet. She got a prophylactic PEG because she had some trouble with swallowing. And this is the worst thing of mass effect. Thankfully, she did not rupture, but she got worse before she got better. This is a 1 month later. I know AICA comes from the aneurysm. I know that part of the aneurysm is going to stay there. This is 18 months later. She's back to normal life independent with a small residual aneurysm that I'm very happy with, and that will probably never grow. You only go away if you shut down that AICA by whatever modality. This is one that we talk about, triple therapy. This, for me, applies to this type of aneurysm. This is a 68-year-old lady present with brainstem compression syndrome and has this monster ostrich-looking type of aneurysm. I like to go to the healthier vert, if there is such a thing. You see that the right vert, the left vert here is more involved by disease, so I flow diverted her from right to the basilar, and I did shut down at the same time the vertebral artery on the left side. And this is this lady 5 years later. For the first 12 months, this lady was on aspirin. Back then, Plavix, now would be Brilinta, and a low dose Arauto, 5 milligrams BID. All tools on deck. And again, last 5 minutes here. Please let me know if I need to stop, guys. Naturally, we have other modalities. This is a 34-year-old guy present with this serpiginous aneurysm. I learned this from a case of Dr. McDougall and Dr. Spatzler at the Barrow. There was an MCA case that I witnessed there. This is just that. This was Halloween season. The fellows called this the ET aneurysm. What the eyes of the ET are just the vascular channels of this partially thrombosed aneurysm, and that's what we're seeing here. So this was just when pipe shield came approved, and we said, oh, let's do a pipe shield construct. Would probably take 12, 13 pipe shields to connect point A to point B. So what we decided to do here, we just did a balloon test occlusion. So we put a small balloon right here on the distal ACA, just proximal to the aneurysm. When you inject the vert, you see this beautiful retrograde feeling of the posterior callosal branch. And then we decided to just go for simple clipping, trapping, and debulking of the aneurysm. You probably could have just shut down that proximal A2, A3 with coiling, with the same result. We decided to decompress, and we did that with surgery. This is another one. You got to be thinking when you're dealing with these aneurysms up front. For example, if you see an aneurysm that is large at the top of the basilar, you got to be thinking, what if this recurs? What is my exit strategy if this recurs? Unfortunately, the colleague that dealt with this first did not thought about that. He coiled, and then he used a laser cut stent. So to put a flow diverter instead of a laser cut is not a good option. Increase by a lot thromboembolic and decrease by a lot the efficacy. If you think that this could recur, a braided stent in our field, in our country, Elvis Jr. for now, more to come, is a better tool to do your initial stent-assisted coiling if you don't want to start with a flow diverter-assisted coiling, because if it fails, then you have a good substrate to put a flow diverter inside. And if you think about the first flow diverter in Europe, Silk, was designed to be used with Leo, that is a braided stent. So you got to be thinking about that. That was not the case for this lady. She was coiled a couple of times, had a stent-assisted coiling, and the mass effect on the brainstem just kept getting worse. She came to us. We did something exactly similar to what you guys saw a second ago. We put a balloon on the basilar, and she has a beautiful PCOM demonstrated on the lateral view here. So we offer her, instead of doing a redo treatment, that could be a Y stenting with more coiling. Because of the mass effect, we decide to go for basilar sacrifice, as shown to us by Dr. Drake. So this is a standard Theriano approach, and we're doing access, and you're going to see the atlas. You see by transparency here, the atlas inside the basilar. So I'm looking for the SCA on the other side. So microsurgical dissection. You see again, kind of a rust on the wall of the atlas. And once I have my SCAs in sight, I use my bayoneted clip to shut down the basilar artery. So here's icy green is not very helpful in this case because of the depth of the field. This is our immediate post-op. Pay attention to the feeling of the aneurysm is still there. And when you look at her 5-month follow-up angiogram, I'm going to show you the still pictures because they're faster to baseline, immediate post-op, and you look at this on follow-up, a beautiful remodeling of the neck of the aneurysm with complete occlusion of the aneurysm. And she's now 18 months later. Other potential strategies, this case probably today would be a flow diverter. We're very early on flow diverter when this lady came to us. She had this dorsal wall aneurysm, pretty large. So she passed a balloon test occlusion. The idea here was clipping of this aneurysm. When I was dissecting the anterior aspect, not even touching the aneurysm, on the anterior aspect, just from touching this wall, the wall was so thin that I had a very pinpoint rupture, controlled the bleeding, did an STA MCA bypass, and then just clip sacrifice the carotid. This is her BTO picture. This is her post-op result. This is her CTA showing the STA MCA bypass. There's another one. This lady has a massive brainstem compression with Ondine's curse. Every time she sleeps, she stops breathing. She had already a tracheostomy when she came to us. We didn't think flow diverter would decompress this fast enough. So we took her for a craniotomy, no pica on the other side. And we did a pica reimplantation on the vertebral artery, and we clipped the aneurysm and decompressed the brainstem. Unfortunately, she was lost on follow-up. She left the hospital alive, but never came back for follow-up. And this is the last one where all tools are on deck. This lady got a clipping for an MCA aneurysm. Every time we tried to bring the clip closer to the inferior division, we would lose. We try picket fence. We try all kinds of different constructs there. This was the best that we could achieve with our intraop angiogram. 9 months later, she developed from that. Probably in retrospect, there was already a component of disease there, but this got much worse in terms of dissection of that superior division. So I knew before when I tried to clip the inferior division didn't work. So I said, I'm going to do a stent-assisted clipping. I put an enterprise there. So I'm going to go to clip. That vessel is not going to collapse because there was stenosis at the origin of that inferior division. So I went there and I put my enterprise on inferior division. You see the stenosis right there. I put my enterprise there and I went back, did an STA MCA to the superior division, and I tried to clip, could not close. This was so calcific that I could not get the clips to close. So I decided to leave. Now I have a sidewall aneurysm with an enterprise already healed inside. This is my aneurysm there. This is my superior division feeling from the STA. So there, did an intra aneurysm. I was worried about these perforators. They were not on the sac. So I just coiled the sac and that was history. With that, guys, I hope I was able to illustrate for you that you got to have all tools available. Endovascular skills keeping getting better, or tools are better. But I think there's role for microsurgical treatment as well. I think it's best for the patient when you have all tools available and you can pick and choose what fits that problem better. Invitation here for you guys, for the young guys. There are all kinds of grants for NNC 2023 in Rio. For the older guys, I'm sure you're going to be getting invitations to join us there as panelists and enjoy a nice environment to discuss live cases and complications and learn from each other. Again, thank you very much for the opportunity, and I hope we have time for discussion.
Thank you very much, Dr. Hanel. It was tremendous. Dr. Monti has a question, comment.
Thanks, Ricardo. Wonderful cases and great presentation once again. My question is with regards to when you've got large volume of coils, flow diverter. I've had several of these patients treated, as you had suggested, endovascular therapy, and then 3-4 years later, they still have headaches, or sometimes for MCA, they might have a seizure disorder, and I have not taken them to remove the coils for removal of mass effect. Follow-up angiogram, follow-up MRA shows no filling of the aneurysm. But I guess my question is, do you have any experience or thoughts on whether it's ever worthwhile to go in there and remove the mass of coils once you've got a quote-unquote healed aneurysm? Thanks.
Thank you. Thanks, Steve. I have one case that the patient had a tremendous mass effect a couple of months later, and I went in to decompress. This was a giant basilar, but the projection of the trunk was lateral. So we went in and decompressed, but unfortunately, the patient, he was already wheelchair bound, could barely walk. So this was a totally desperate measure. Ideally, we'll discuss this when we talk about combined. It'll be phenomenal if you have a way to just reconstruct the lumen and go there once the blood cannot get on the aneurysm and fix the sac but I think that is still pipe dream, not pun intended to pipeline. I think this is not what you described, pain specifically, because this is much more common in anterior circulation. I think you got to coach the patient. So like a giant cavernous that you're going to coil or just flow diverter. I have a couple of patients that they are not happy surviving with this miserable trigeminal neuropathy, and this can happen. I think you've got to be open about it. And if it happens, it's not a happy ending for the patient, because they change it. They turn an ophthalmoparesis without pain to a very painful trigeminal neuropathy, with or without improvement of the ophthalmoparesis. So I think you've got to be cognizant of that. And then to decompress is hard because of the location of the aneurysm, and you're in a tough situation. But I think it can happen. I think endovascular sometimes help when you go for this microsurgical decompression. But in general, it's harder, right? Because the coils become a mass. So I think ideally we avoid that. Medical management.
Dr. Hanel, we have a couple of questions. First of all, what's your experience or your thoughts on cranial nerve neuropathy recovery after flow diversion plus coils or flow diversion alone?
Yeah, we have not measured that one, but we measure flow diverters specific for second, third, fourth, and sixth. So for cavernous and optic neuropathy, we have a recovery rate, and we published that. So if you look there, there's a paper on Journal of Neurosurgery that we published early on with 44 cases with a super nice improvement, better than coils and better than stenosis coiling, very close. Again, if you talk to microsurgery, die hard, I don't know if you know any of them, Cameron. They'll say, "Oh, with surgery, everybody gets better." That's not what is there in the literature. If you look at Art Day series for optic neuropathy, again, that's about a 70% improvement, 60% improvement, give or take, for microsurgery. The numbers that we got with the flow diverter, and again, this was not a flow diverter plus minus coil. We did not look into that. I think that's a very interesting question that we should try to measure if that makes a chance or a difference or not. The flow diverter numbers seem to be better, but again, this is a single arm comparing with literature, so you know that this could be a bias right there. But it seems that flow diverter has a higher rate of recovery of the cranial nerves compared to coil, as good as many series of microsurgical clipping on the literature.
Okay, Leo?
Hey, Dr. Hanel, quick question. So when you're putting coils for a giant aneurysm, is there, you hear a lot the term loose coiling, so it's probably a different strategy than when you're coiling primarily a different aneurysm. So when you're coiling a giant aneurysm, do you have a specific density or a specific goal angiographic that's a little bit different than other aneurysms?
Yeah, I coil a lot, man. I don't think I would use the term loose coiling. It's not a coiling for an aneurysm that I'm doing coiling alone. I think I don't go below 5 millimeters on the coils. But again, I keep pushing till I see a black. You saw the case that I showed that we did with Eric. That we stopped because there was no flow in the aneurysm. That's, I think, is a hint when to stop, because in these giants you can keep putting coils, and we did a rupture last week with Dr. Neem. We put 47 coils on an aneurysm. That's a different situation. But I think one or two coils, I think you have to have a mass enough that is going to decrease the thrombus on that. And I think I learned that from that case, that rupture in the coil mass block the hole at the top, the coil mass move and tamponade out the rupture. I think you got to have a bulk of coils enough to do that. And we do change catheter position. Tried case that I did was a 15 millimeter did last week. Multiple daughter sacks. So I'm pointing my coil catheter. I want to get coils on the daughter sacks. I want to protect that because I'm worried about delayed rupture on that. So that's a vague answer to your question. But then I don't like 2 or 3 coils. I think it has to be a meaningful coil. It's hard to define that, but the have to look black at the end, not a bunch of little loose wires there.
Dr. Hanel, your paper from the Buffalo group on triple therapy was on fusiform aneurysms, right? So do you think that can apply to a giant saccular, maybe to avoid very fast thrombosis and expansion in fat men?
Yeah. Yes. So my concern on that, Matthias, is delayed rupture, right? So the lady that I show here, 39-year-old, my concern on that lady is much more delayed aneurysm rupture than a perforator, because again, we used to go crazy. Cameron, remember when we started, our longest flow diverter was 20 millimeters, so we were connecting one to the other, sometimes 12 flow diverters to treat a carotid, drawing a pretzel inside the aneurysm. That's not the case anymore. In general, there's a single device that creates the morbidity of perforator stroke with a single flow diverter on the basilar artery. I would call it low. So I'm not worried about it. Very different than these patients that are represented on this study that you're quoting, where you're talking about, in general, this dolichoectatic hollow basilar, those are atherosclerotic aneurysms. So that, I think, perforator is a problem, much more than delayed aneurysm rupture. So I have a lot of respect for this complication, delayed aneurysm rupture. So on those sacral aneurysms, I try to stick with my aspirin and Brilinta.
Okay. One other question is, do you have any experience with remote ICHs in your?
Yeah, I have to say I was very lucky. I'll never forget. I present in Jackson Hole my first 50, and Jacques Dion, that is a giant of interventional neuroradiology, present his first 50. I had 0 parenchymal hemorrhage. Jacques had 3 or 4. So I think that's a tremendous discussion. I've always been very neurotic about P2I12. That has been for, again, 15 years maybe that we're using the tool. Maybe that has to do, again, as I said during the presentation, Cameron published on that, where they found foreign body debris. And again, if you look at the way these devices are approved, there is a certain tolerance of how much debris we can have from these devices. So everybody knows when devices approved that they do provide debris, and to a certain extent it is tolerable. In this foreign body, as well as air embolism, they're more prone to create hemorrhage. If you look at any DWI change for stroke in general, you see that 20 to 30% of those who have microhemorrhages on follow-up MRIs. So for me, that's the parenchymal hemorrhage, an ischemic insult with or without foreign body in a patient that is a P2I12 of 5, 10, super inhibited on dual antiplatelet. I'm a bit disappointed that on SHIELD, we're not seeing a reduction. There's a paper from Greece published on JNIS showing a significant drop on the WI hits. The paper that we're about to publish, about to submit, is very similar to the series that Leo put together for us early on. We're not too far from that. So the WI hits are still there. But the parenchymal hemorrhage, I think it got better over time. Maybe because of the change on the hydrophilic coating. I'd love to hear Cameron's opinion about that one. It has more gray hair than me.
Well, no, I mean, the numbers definitely dropped. You know, I was in the Jacques camp there where, you know, we had a couple parenchymal, which really, you know, stimulated the paper. Was we had 2 parenchymal hemorrhages. I think in my first 10 cases, I think I had 2 hemorrhages. It's pretty devastating. And, you know, I, knock on wood, haven't seen another one since. And so what changed really were I think the guide catheters and the intermediate catheters and everything. You know, the original ones, tolerances were very tight, and you were, you know, pushing with both hands, scraping all along. And I think that's why you were seeing the foreign debris. And I just, you know, there's still some of that, but I think to a much less extent. And you know, thankfully, it's a much smaller problem than it used to be. It's not zero, but it's a lot better.
Yeah, totally agree.
Dr. Hanel, one question for the young people like us. What is your strategy to cross the aneurysm? Do you have any special tricks or giants?
I think you have to have ideally a good view of the neck of the aneurysm, and I think that's where we are very fortunate, right? We happen to do cases in places that don't have a biplane. So I think the biplane is super helpful. You can keep your 3D is very helpful to define little trick. Superior hypophyseal aneurysm, I like to get my C on this shape. So my aneurysm is right there on my AP view. I'm not looking at the in and outflow, but I know that if I touch the outer wall of this, I'll get to the other side. So you got to strategize. I think it became much easier because of our tools. Distal access catheters made our life easier. I think what's going to be very interesting, what's going to happen with Bandit. I know John Barr just did a case a couple of months ago where he struggled a lot. He's a very experienced operator in Dallas. Struggle a lot with in and out, hula hoop, go inside, around the world, trying to get to the other side, whatever you call the maneuver. I think it helps. And we did one a couple of weeks ago that we had to do there, go on the other side. the Phenom 27 is stiffer than the Marksman. When we used to do that with Marksman, all you had to do is to pull the Marksman. As long as you have distal purchase, that would reduce. The Phenom 27 is a bit stiffer. It doesn't do that. So we had to put a solitaire there, invest the cost of the solitaire to anchor the Phenom 27 and take the loop out. You can do that also with the flow diverter inside, but then you're exposing yourself to stretching of the device because you're gonna have to anchor the pipe and then pull on that or whatever flow diverter you're using. But the Bandit is a steerable microcatheter, right? So if you look at what you're doing, you can go and point your tip of the microcatheter in the direction that you want your wire to go. And I think that'll be very interesting, useful tool on our box to cross this neck of a complex giant anatomy.
I have one last question. Do you do anything with the inflow stenosis? Because many of these cases have stenosis on the inflow vessel.
Yeah, I think the vast majority of this is related to external compression of the aneurysm into the parent vessel once you put the device there. And that's why I still like a lot pipeline for this. I think the chronic outradial force of pipeline resolved most of those. I think I have 2 cases that I had to use a balloon mounted stent inside the flow diverter to open a severe stenosis that I was worried about. You got to remember that if you look at all this delayed aneurysm rupture, stenosis either on the in or on the outflow seems to be detrimental for that, and patients have more delayed rupture if they have stenosis around the aneurysm, especially if it's outflow stenosis. So we try to pay attention to that, but in general, that resolves with stenting of the vessel.
Okay, Dr. Hanel, thank you. I don't have any more questions, and we're just in time. So thank you so much for your time. It was tremendous.
Thank you, guys.
Great seeing you, Ricardo. Thanks so much for coming.
Great seeing you too.